Welcome to this webinar on the QASA Reimbursement Toolkit. I think this is an amazing initiative on behalf of QASA because I think it's going to really be of assistance to QASA members and non-members for that matter. So I just want to go through the origins of the toolkit. Why it came about is because where it started was where QASA members were particularly frustrated by what they were experiencing with reimbursement and engaging with their medical aids, etc., to get things funded. And it was very much a reactive type of approach where we got involved to provide support to members on how to engage with medical schemes. It is quite complex, and given that complexity, didn't make things easier. Not least of all because it was reactive. So we needed to really have some systematic approach to how we could recommend going about achieving reimbursement for the things that you need. It will be online on the QASA website. So this is intended to guide you on how to navigate through complex reimbursement processes and prepare you for escalating inquiries and appeals against decisions made by your medical aid. It's applicable to any reimbursement pathway and process requirements, including assistive devices and medicines. It is structured in 4 logical steps with 2 forms and 5 appendices. Each step will really just try and explain your engagement at the beginning of the process with your service provider or healthcare practitioner, be it a nurse or doctor or a clinic or hospital. Then it will move to the next step that will talk to the application for reimbursement to your funder. And by the way, I use the term funder and medical aid interchangeably. Funder, on the other hand, has broader meaning in terms of not only private funder, it could be other forms of funder like government, or not that government comes into this necessarily, but it could also include for you the COID, or Commissioner for Injuries on Duty, as well as Road Accident Fund. The third step will talk to handling responses that you might get from funders, and those responses will typically be declines for whatever reasons, and we've collated a host of different or anticipated responses that you might receive from your funder. And if they don't appear in our collection, we'd very much like to hear if you have any different or new ones to what we've collected, so we can add to this for everyone's benefit. And then last but not least, we're going to explain how to use available complaints and appeals mechanisms to escalate your application for reimbursement. Each of these will come with a set of activities to ensure that you collect and use the correct information. This is a critical part that you need to spend some time on to give you a better probability for success in the process. We'll try our best to explain principles and concepts. These are provided where relevant in a specific explainer section, which is Appendix 5, I think. Then there are relevant templates and checklists provided that you will use or adapt or modify, whichever way you see fit. Then I must just state that this toolkit must be seen as a reference only, subject to change, and it will become easier for us to change if it's online, and may not be reproduced and or distributed in any form. And lastly, it doesn't represent any statement or guarantee that that anything is going to be covered or you will achieve successful reimbursement. So it's not necessarily a promise, unfortunately. So don't hold us to it. But the idea is to follow this literally to the letter to give you the maximum chance of success. Some orientation. There are 4 steps which I spoke about. There are 2 forms, one of which is how to or what you need an informed consent form. Elsaby will talk more to that. Then there's an appeal form that you're able to use should you want to escalate your application upwards to senior decision makers within the medical aid environment. And then the whole string of appendices that carries a lot of information that we will go through. To start with the steps, what you'll see first will come come across first in the process is the first part of the entire process with respect to your engagement with your healthcare service provider. So you would present for treatment. You're either presenting as a new patient, or you're presenting down the road at some stage where you might have some complication, or you're just presenting for a follow-up session where your treating provider will prescribe you. For example, let's stick with catheters since we're going to be using that as an example. There will be a process of assessment and diagnosis, and then consent to treatment, where I'd like to invite Elsaby to come and talk to the first form you'll engage with. Elsaby, can I open the form for you?
Yes, I can talk to that. Thanks, Mark. So, hello, everybody. I haven't said hello. It's nice to be with you all. So this form is just an example of an informed consent form. And why we've put that in there is because it is important that the patient and the provider talk through this process of agreeing to, for example, a particular type of catheter as treatment. So that form should contain the doctor's details, your details, and then what the law says is you need to know your health status. And Mark will also talk there about the various codes, because in the end, understanding what your health status is and why a particular option or options are available for you in terms of treatment is really, really important. So the health status, so knowing what your health is at that point in time, and then knowing what's the treatment options, the benefits, the risks, and the implications. So if we talk catheters, the implications of using a catheter, the frequency of change, etc., is very important. The options that's available to you is important. The risks associated with some options, the benefits of others. And the better you understand that, the easier it also is to have the fight, if you must have a fight, with a funder. And then the costs must also be discussed. And then in an informed consent form, one will say, yes, after all of this, I agree to X treatment. And this is the same process, whether we're talking catheters, whether we're talking medication, whether we're talking a hospital admission, whether we're talking a scan or whatever the case may be. But the better this first process is, the better, because then you and the doctor are discussing what would be the best for you. And in the end, you will agree to that.
I'm going to go back to step one, where I will just give you an explanation of coding and what types of codes exist and the importance of correct coding. So to start with, doctors use a system of coding. It's from a document that has been created by the World Health Organization, which contains probably upward of 10,000 plus different codes. Okay, so this really serves to translate the written description of a medical and health information in your diagnosis into a code. Now, doctors have to use these codes whenever they treat and make their own claims to be paid for the service provided. So this doctor's diagnosis must be accompanied with the correct ICD-10 code. So international classification acronym is ICD-10. So that's one of the main codes you will be making sure is correct as you go through this process and prepare your motivations. It also, bear this in mind, I'll talk to this next, will identify whether a health condition falls within what is called a prescribed minimum benefit. So it's important that all of these codes, all of these ICD-10 codes are added, specifically those that are prescribed minimum benefits. All right. Just by the way, you'll see later that World Health Organization uses the term tetraplegia, which is nothing more than a technical term and should be read as quadriplegia, please, because I think that is That is a term, that is terminology that you're much more familiar with. All right. Then on to prescribed minimum benefits. What are these? PMBs require that schemes provide full funding for all defined PMB conditions, naturally within certain boundaries, and I think Elsabe will probably talk a bit about those. They may not be taken, the funding or reimbursement may not be taken from a member's savings account and must be paid in full without co-payment. My point there is that if it's determined to fall within the scope of prescribed minimum benefits, by law, the medical scheme has to pay for it from a different source, typically from what they call the risk pool. That is a specific benefit that is separate from your savings account. Those of you who are using savings accounts will understand that it's definitely a finite amount of money and can be exhausted very quickly. All PMBs currently cover emergency, chronic conditions, and what are known as diagnostic and treatment pairs. And this is for 270 medical conditions that probably cover about 7,500 ICD-10 codes. So it's quite complex. So this is why it's quite important that any ICD-10 code that is identified relevant to your condition up front must be identified and listed. Then we can take that and determine its PMB status. The DTP links a specific diagnosis, meaning your ICD-10, to a treatment and broadly indicates how each should be treated. So based on what has been proven to work best in scientific circumstances and taking into account patients' specific needs and experiences. And this talks to the principle of evidence-based medicine as well. And this is the ideal where your PMBs should be designed around evidence-based medicine, taking best available evidence, your healthcare provider's experience with treating, in this case, spinal cord injuries, and your own personal circumstances. That is, in a nutshell, the principle of evidence-based medicine. The biggest problem, and some people, Richard mentioned earlier that many people still talk about difficulties getting their motivations or authorizations approved. For the most part, it's often related to the use of incorrect codes. But so I cannot emphasize enough that it's important to get this right up front. So it's vital that the doctor chooses and includes the correct PMB and ICD-10 codes in their motivation letter. A quick example, since we are talking about neurogenic bladder, and in fact, neurogenic blood as well. And so this is specifically listed as prescribed minimum benefit, or PMB 213A. The ICD-10 codes relating to the condition, whether paraplegic or quadriplegic, are from G81 to G82.5. And then the ICD-10 codes relating to the bladder condition are from N31 to 31.9. And just as an example, and this is exactly how you will see it, this incidentally is in the public domain. It's on the Council for Medical Schemes website. Lastly, in terms of coding, from an importance perspective, is that over and above identifying what your diagnosis is and whether it falls within a prescribed minimum benefit that has to be covered in full, there are components of that need to be paid for, including any of your suppliers, be they medicines, assisted devices, catheters, for example. So these things therefore need what is called a NAPI code, but nothing to do with nappies and diapers, but more to do with what they call a National Pharmaceutical Product Price Index. Also not limited to pharmaceuticals, but broadly speaking, any medicine or device that is going to be claimed from a medical aid has to have a NAPI code. So at the same time, where either at motivation stage or post-treatment in your claim stage, when these are submitted to your scheme, a NAPI code must be included. So this is a unique code that your doctor needs to make sure they're using, and you need to make sure the doctor is using the correct code on your script. The best way to ensure that you don't go backwards and forwards between your doctor, pharmacist, and medical aid is to get all the facts correct before the script, and the claims are sent to the medical aid. So it must accompany the motivation at all, if at all possible. Either you, the practice or health facility, submit to this to your medical aid. Let's talk about the prescriptions.
So with the prescription, it is important to check whether your medical scheme has got particular requirements for the prescription. So do they, for example, say they only allow a repeat for 3 months, or for only a first time, and then after that, numbers of repeats? It's also important to check the numbers of items and the codes. So sometimes it may be important to split prescriptions and to not have a single sheet of paper with more stuff on. And then making sure that the prescription has that ICD-10 code, the diagnostic code, on as well. There is a tendency by some practitioners to just use the so-called Z codes, and that's then problematic because the scheme cannot link the prescription to your PMB condition. So, and then from a pharmacy level, the claim to the scheme that they then submit must contain the pharmacy, or if it's an in-hospital generated prescription, it must contain the practice code number of that pharmacy. So that identifies the entity that claims from the medical scheme. So the prescriptions are really important that it is done correctly. And if you've got a healthcare provider and a facility that uses electronic mechanisms and so on, it often goes quite fast because they don't need to repeat all of your details every time.
Thanks, Elsabe. And if I may ask a question at this point, and I'm not sure if anyone else is thinking about this, but how does the prescription and what information in the prescription is different to what is in the motivation?
Oh, that's such a good question. So the prescription must be aligned for medicines with the medicines regulations requirements. So they want, for example, the patient, apart from the medical scheme details, they want to know gender, they want to know an address, and all of those types of things that are that it's actually in Regulation 33 to the medical scheme, to the Medicines Act. So it is determined by that. It will not be the motivation as to why you need the treatment. All that this will be is to say, this is what in the end was formally written down for you as part of the treatment that you've agreed to. So it is a critical way because medicines and medical devices cannot be handed to a patient without this. So this is much more making sure that you get the product in the end. The motivation may need to precede this, or in most cases, the prescription will be attached to the motivation to say, this is what this patient needs. Here's my prescription. And this is why I'm saying that. So a prescription is kind of the formal order to make an order for that medicine or that medical device.
Thanks, Elsabe. So it's a distinctly separate document to the motivation, which that's why I'm bringing it up, which needs to be part of the compendium of information that you might need when we, if and when we need to escalate this.
Exactly. Yeah. So this is on the motivation, and you'll see it links back to the discussion that you would have had with your doctor or your other healthcare professional in terms of your condition. So to understand the motivation is to also understand what your condition is. So why would you need a particular intervention or a particular treatment given your specific condition? The second thing is, what will this take from me? So if I have to change catheters in a work setting, how will that work? What will this mean for me? And that also influences, those factors influence product choice. If we talk about medicines, for example, a particular medicine that one needs to take, that you may need to take in the evenings because it may make you drowsy, or the choice of the medicine will depend on what your needs are. So knowing what it would take from you as a patient to be on that treatment is really important. Then thirdly, one would need to say, what happens if the scheme, the scheme, will they fund this or won't they fund it? And if I choose something that the scheme will definitely fund, but it is not the appropriate option for me. So that means what they fund is not what 1 and 2 says. So what my condition mean and what it's just not suitable. And this is why point 4 is about the appropriateness of the particular care. And if one does a motivation to a medical scheme, this word appropriateness is really important, because one needs to say, this is my condition, these are my circumstances, and this is why I need this particular product. This product is appropriate for me. And this is why one then conversely will say, yes, what you guys will fund in terms of point 3, that I will not be okay on it. So to think about those things before one actually do the motivation is important. And then to understand, and this is where the doctor plays an important role. Why would a particular product be appropriate for me? And why would a different thing not be appropriate for me? And this is where in the motivation, the doctor may insert references to clinical guidelines. And SASCA is good with that. They've got great guidelines to say how things should be. There are many of these evidence-based documents that says a patient like you need that. A patient like that could suffer these consequences. So understanding why is really important. Then the 6th thing is, if there are alternatives, so we're back to 3, the scheme says, oh, we only fund something else. Will you be okay on that? Because if it's yes, then it's fine. But if it is no, you need to understand why it won't be okay. And that must be included in the motivation. So what will happen if I am not okay on what the scheme would fund, or I'm not okay on an alternative? What will happen to me? Not what has happened. Sometimes we can say this has already happened, but we can't always say that. We say we're choosing a particular product to avoid something negative from happening. And it's really important that we discuss that and we think about that, what could happen. And that would then be something that we'll include in a motivation. So all of these 7 things would need to be in the end things that you consider and understand and that we'd want in a motivation. So, and that then brings us to how a good motivation would look. So it would have the patient information on it. It would have the practitioner's information on it. It will have this assessment and diagnosis. Okay, and this is where the previous things that on the previous slide, the bulk of that comes in there. Then the treatment that is required, and this is where this, why do I need this? What does evidence-based medicine say? What does the rules of medicine, the rules of healthcare say a patient like me should be getting? Then also in that regard, it may be important to give proof of one's condition. So test results, previous hospital admissions with, for example, a UTI or something bad that had happened. So things that could also put you, how do you fit into the evidence-based medicine? Then making clear the conditions and consequences if you don't get the appropriate treatment. And then this last bit is really important, to describe if there's been treatment failure. So if you've been on something else and it didn't work, or it didn't work appropriately, or there's been harm, or you suffered an adverse event, a negative thing happened to you. And this is where the law also say, or it could happen to you. Then you need to describe that. So if you've in the past had infections, you need to say, we want to prevent these infections because it's bad for my kidneys, and we want to prevent that harm from occurring again. Or it's been totally ineffective, and this is the reason why it's been ineffective. Then if the scheme has got a rule in terms of designated service providers, one would need to address that, and we'll get to the designated service providers a bit later on. And then in the end, obviously, we want both the patient and the doctor's signatures on the motivation to kind of say you're all in agreement on this.
Can I just present a scenario? And I'm aware of situations where patients have been told by their scheme, well, we'll only pay for something if it happens to you, suggesting that you must wait until you be harmed. Could you talk to that particular point, please?
Yes. And this is where we have that absolutely flagship case that Storm Ferguson, the late Storm Ferguson, won against one of the big funders, where they said, because we knew that there were harm in the past, but we couldn't prove it. The records were lost. But the research, the data showed that patients in that position would face harm. So that potential of harm is enough. And the only thing that we need to be able to say is that that potential of harm is not a thumbs up. We know it from research or write-ups or articles, or we know it from, the doctor can know that from experience, that something would happen to a particular type of patient. So medical schemes, the law explicitly says, cause or would cause harm. Okay. And it's the same with the treatment failures. We don't want somebody to face a really bad thing and land up in ICU in hospital. And only then do we say, oh shit, we should have paid for this. You know, it's in any case a violation of the ethical rules to wait for harm to happen and not to prevent harm. And that's why the ethical rules for doctors and everybody says do no harm. And that means don't wait for the harm to happen before you act. So that argument by medical schemes, one can refute with reference to Storm Ferguson's case.
Moving on to step 2 then, and granted, we've spent quite a lot of time on step 1, but it is important because it's probably the step where you have to be quite conscious of the type of information that needs to be specific and comprehensive. For the rest, the next 3 steps are more about process. Okay, so from step 1, we move into submitting the motivation. We submitted our application or motivation to a funder. In this context, we're going to stick with medical aids. Right, so it gets declined, which is assuming why we're here. We're learning how to deal with these declines. So if you choose and have the energy to persevere, and trust me, you're going to need this energy, not only you, your family, and your doctor. If you choose to exit, then that's your prerogative. However, if you have the courage of your convictions that you want to certainly lead a good quality of life going forward, then challenge it. So you may then, and have every reason to request the reason for the decline. And at the same time, you have an opportunity to refer to a rebuttal sheet. It's all of the types of things that we've heard from patients who've been declined benefits from their scheme. So their objections or declines, we've put some rebuttals to these, which can be scientifically based for the most. Yeah, so now we've addressed the rebuttal sheet. We've moved quickly through that. We're going to step 3.
So medical schemes sometimes say you have to use you have to go to a particular doctor or a particular hospital. They sometimes even say a particular product supplier is a DSP. Now, the law says you are entitled to go to a non-DSP if one of these 3 circumstances are in place. And those circumstances are important because if you can prove that they're in existence, then the scheme must fund the non-DSP in full. So the first one is if the DSP is too far from your house or work. And that means that the DSP is inaccessible. And for the members of your organization, this has a particular important element to it, because for you, it's not as easy as it may be for somebody else to just quickly jump in a car and off you go, or jump in a taxi and off you go. So it is really important that one makes this clear to the funder. If the funder says, sorry, you have a big copay because you went to a non-DSP, you need to say to them, listen, the DSP was too far from my house or my work. Now, normally the CMS says 50 kilometers, but in Joburg, for example, even 10 kilometers can be too far, given traffic and all of that. So one needs to be able to say that it is really difficult. The reason behind this is to not shift the cost. Oh, sorry, DSP stands for Designated Service Provider. Thanks, Joshua. I've been really stupid in not saying what that means. It's a Designated Service Provider. So if the Designated Service Provider is too far, then, then it doesn't help, because all that they're doing is they're shifting the cost to you. They're saving, but you need to travel and make all kinds of expensive arrangements in order to get to the DSP. The second reason is when the DSP cannot render the services. And if it is a product DSP, they can't provide the product. So in some cases, we find that the type of support that you need, the type of doctor that you must see, is not available at the DSP. Then you are entitled to go to a non-designated service provider. The third circumstance is where your condition requires immediate support. So that's not necessarily an emergency, but you actually have to go and you have to see somebody, and the DSP, the designated service provider, can't see you. You have to wait too long, and they don't have, they can't see you when you actually need that. So those are the three exceptions to designated service providers. If these don't exist, they can levy lawfully a copay on you if you then choose to go to a non-designated service provider.
On to step 3. So here we've come from those, from step 2 into step 3A. So 3A describes the situation where, okay, so we want to escalate, and a rejection or a decline has been given. You and or your doctor decides, no, hang on, let's challenge this. We want to engage with a medical advisor, and all medical schemes usually have a medical advisor who will use some intelligence to make the right decision. They'll invariably ask for additional information, hopefully not too much. If all of your original information was correct, you're talking about the coding and other stuff that went into your motivations, etc., and your consent forms. And then it goes back to the medical advisor, and a decision is made, and it's either approved, or if it's still declined, it moves on to the next level of appeal. At that point, on the other hand, step 3B would suggest, well, we don't have to give you a reason, or there's no reason given. So we have a process whereby we can appeal and use the internal scheme or administrator's appeal or disputes committee. And before we go on to step 4, Elsaby, could you talk about the appeal? This is form 2. Yes. So this is a template that one can actually use or modify to suit your appeal process.
Good. And this internal appeals process is, and it will follow exactly the same recipe, even if you escalate this. You always have to say you've declined. And this is the most important thing people sometimes forget. You have to have some proof that there's been a decline. Sometimes people say, yeah, but they told me over the phone. Then you need to say, over the phone on this particular date, you said that. And then we want to say, what did they say when they declined? And this is also why it's important to sometimes be a bit combative and to say, why are you saying that? Where do you get that from? Where is it in the rules? So to ask these questions. Then one would say, remember, my condition is a PMB. So that's really important that you state that. And remember, this PMB must be funded in full and without copay. So you set the scene immediately there. Then you talk about the copay that could be levied if I would have been okay on that product and I voluntarily choose something else. But if I am not going to be okay, one need to talk about what evidence-based medicine says, and one need to say all of the things that by now you would know that comes from the motivation. What was the harm? What is the risk that you're facing, etc., etc. And then it's so important to attach the documents. Attach your consent, attach the motivation, attach the evidence-based medicine things, attach the proof of harm or the risk or what else you have to show why you need a particular treatment. So these attachments, if you do this right up front, you can take the same packet of information, can help you straight through, even at the Council for Medical Schemes. And then there's a little thing right at the bottom there where we say, and just remember, if I suffer harm, we can hold you liable as a result of that, because we've told you that there's going to be this potential harm. So some people don't want to add that last bit. They say it sounds like a threat, but it is something that one could add if you're so inclined. If you're like me, you are combative, then you would definitely include it.
And this would be the first appeal via medical aid internal processes. So then we get into step 4, where if it's either still declined, notwithstanding your internal appeal letter to the medical advisor or principal officer, or if there's further no appeals of dispute committee and you choose to pursue it, then the Council for Medical Schemes, the CMS, as the regulator, has a specific complaints process. All right, so this would be the next level of escalation or appeal, where they very much are there to support you as the scheme member.
Yes, and this is exactly where one would then make sure, because if you've done everything right from the start correctly, it's really easy to do that complaint at the CMS, because then you just attach everything. And if you've done an internal complaint, and some schemes don't have an internal complaints process, so you would skip that stage, but your letter would be exactly the same as your internal appeal letter. All that will change is the beginning bit. You will refer to say, I did do an internal appeal and they still said no, and you will attach that thing where they said no or how they argued why they're saying no. So, and it is important to keep you'll see, we also recommend how you label your annexures. A lot of this, the CMS, you can now file online your complaint. And if you label your annexures nicely, so you'll say, let's say mine would be Clink versus ProfMed motivation annexure A, Clink versus ProfMed reason for decline annexure B, so that it's easy for them, even if somebody somehow misplaces any of the documents, you've got it all there and they all are clear what is in that particular document. And any other correspondence that you would have had, people often have had numerous attempts to resolve it. Your doctor might have spoken to the medical advisor, and the medical advisor might have said, no, we can't consider this. All of that then is really, really important that you attach all of those.
It is so important that you would have been expected to follow the internal process of your scheme if it exists. Because if you go straight to this part and escalate straight with the regulator, and not having followed that process, they're less likely to entertain your complaint. So please be aware of that. So I wanted to conclude by making reference to Appendix 3. It's the reimbursement checklist. So this covers almost everything we've said in 8 sections And in the toolkit, we unpack each of these with further questions, other information relative to each of these. So talking to your doctor about your condition and consent, about P&Bs, when preparing motivations, what to do when a motivation is declined, designated service providers, the issues around formularies, whether the product prescribed is on a formulary, whether this is part of a managed care policy or protocol. And by that, I say the scheme will say, no, our policy says. It's like the other one, our rules say. Then you are fully entitled to say, well, what are those rules? Because you actually have every right to request this. And that couldn't be more explicit in the law itself. So please ask that question. If the rule book, as it were, is thrown at you, then please insist. Either you, certainly your doctor may do the same, and quite frankly, any family member could be asking the same question. But by law, they have to reveal what the policy is. And then lastly, as Elsaby has just gone through, it's how to go through the complaint process, escalating complaints to the Council for Medical Schemes. So, ladies and gents, that concludes navigating through the toolkit